Hi, everyone. My name is Dr. James Beck. I am the Chief Scientific Officer at the Parkinson's Foundation. I want to welcome you to our third in our series on expert briefings, The Skinny on Skin and Bone Health. I love that alliterative title. I want to also welcome our Facebook viewers as well, who are viewing this expert briefing live. As I mentioned, this is the third in our series and the last one for our 2021 year. We'll start our next one in February, so we'll have a little bit of a hiatus for the holidays and welcome everyone back. I want to orient you and really excited about our topic that we're going to have today. If we have the next slide, yes, two of our speakers are going to be talking today, and also want to orient you to the screen. So what you just now see is an inset of what you hopefully are seeing as well. I just want to go through it briefly just so everyone knows what the different buttons are and what they can expect. So the arrow is showing the chat button. So the chat feature is going to be where my colleagues are going to send information to you. So that is going to be where we'll put a link to the slides for this expert briefing. So if you want to download a PDF version of that, you'll see that there. There'll be the welcome message that my colleague's going to share and other information for you. If you have questions that come up during the talk for our speakers, that's where the Q&A button is useful for. So click on the Q&A and you can type in your question. We'll do our best to answer it on live during our expert briefing, but we may not be able to get to it. So we have our really great group of colleagues who run our helpline. They can help answer our questions. And so either we can do it live or we can perchance answer it after the fact. The next button is something new that Zoom is offering now. It's called a live transcript. So for those of you who may have a hard time hearing or you are someplace that's loud or noisy, you can click on that. It's going to be a computer-generated transcript, so it's not going to be great, but it will give you a good sense of what the what we're talking about and what the speaker's talking about. And if you were to miss this, of course, you'll be able to come back and watch this at a later date. If you find this as great as I think you will, share it with your friends. They can come back to the Parkinson's Foundation website and be able to watch it again. So let's go on to our next slide to remind everybody what the mission of the Parkinson's Foundation is. Our goal here as an organization is to really improve the lives of those who live with Parkinson's disease. And we do this on a day-to-day basis, steadily trying to improve their lives today, also work towards a cure for tomorrow through the research that we fund. And importantly, we really engage the Parkinson's community, our audience here, to understand what the needs and priorities are. So we're frequently engaging people with PD to get their opinions. They're there to help us determine what grants we should fund. They're there to help us set the tone and urgency as our organization. So the next slide will show that we have three goals as an organization. As I mentioned, improving care for everyone living with Parkinson's disease, advancing research towards a cure, and also to educate our global community. And this is where we are really hitting that in spades with our expert briefings. So hopefully we're able to educate everyone so they can improve their care. And we'll also talk about research that you as an audience can partake in to help advance us to better understanding Parkinson's disease. So I want to give a shout out and a big thank you to Genentech. It's a member of the Roche Group. They are our funders for the season. So thank you for that. Without their support, it would be difficult to put on these expert briefings on a regular basis. So thanks to Genentech. Also, as I mentioned, we'll have recordings for expert briefings. They're generally about a week when they'll be made available and archived. And as I mentioned, and already there in the chat is a link you can click on to download a PDF of the slides for today's presentation. And we have a poll right here for getting to know you. So if you are on Facebook, the poll won't show up, but please go into the chat and let us know whether you're a person with Parkinson's, you're a spouse or partner of someone living with PD, if you've got a family member, or you're a member of the healthcare community. With that, we can get a good sense of who our audience is today and adjust on the fly, depending upon who's listening in today. We always get a really good array of individuals who seem to be involved. So feel free to move forward with that. And let's see if we have results coming up soon. Yeah, not surprisingly, our biggest members of audience are those living with Parkinson's disease. Welcome. And we have a few healthcare professionals in here as well, which is great to see, as well as the care partners of those living with Parkinson's disease. So let's move on and talk about our presenters. As I mentioned, we have two fantastic presenters today, talking one about skin health and the other about bone health. So our first presenter is going to be Dr. Nikki Nieman. He's an assistant professor of neurology at Muhammad Ali Parkinson Center, which is also a center of excellence. And he is at the Barrow Neurologic Institute. Dr. Niemann's expertise includes the diagnosis and management of Parkinson's disease and other movement disorders. He has research interests that include clinical trials, translational research in Parkinson's disease and other movement disorders, genetics of Parkinson's disease, novel applications of botulinum toxin, and of course, skin issues when it comes to Parkinson's disease. Also like to welcome and introduce Dr. Kenneth Lyles. Kenneth Lyles is a professor of medicine at Duke University. Dr. Lyles is a graduate of the Medical College of Virginia in Richmond and has over 47 years of experience in the medical field as a geriatric medicine and bone disease specialist. At Duke, Dr. Lyles has been helping patients with metabolic bone diseases and other disorders of mineral metabolism and finding ways to treat their disease. Dr. Lyles' research interests are expansive, include hip and vertebral fractures, Paget's disease of the bone, age-associated osteoporosis, and fracture prevention in Parkinson's disease, among many other of his interests. Dr. Lyles also currently serves as a president and trustee of the National Osteoporosis Foundation and is a lead investigator at Duke for the trial of Parkinson's and zoledronic acid, a TOPAZ study, which he'll touch on briefly in his talk today. So without further ado, I'd like to introduce and welcome Dr. Nieman, and I will sign off and let you speak. Thank you, Dr. Nieman.
All right, thank you very much for the introduction. I'm just going to share my screen here. I trust that everyone can see the slides. And everything should be on the center screen right now. All right. So
yes, very good. Thank you very much.
Perfect. Thank you very much for the kind introduction. I'm very excited to be part of this educational session about Parkinson's disease and skin and bone health, along with the Parkinson Foundation and Dr. Lyles. It's a rather big topic, so I won't be able to cover everything in the minute details. For those who have further interest in digging into some of the finer details, this article that I wrote with my colleagues, Andrew Bilnitzer and Joseph Jankovic, published earlier this year, should be accessible through the library and at least in abstract form online by Googling the title of the paper. Another great resource for information about skin changes and a lot of other things in Parkinson's disease is, of course, the Parkinson Foundation website. If you're not one for typing in long URLs, you can simply Google Parkinson's Foundation skin changes, and this page will be the top link on Google. The conditions I'd like to talk about are skin disorders that are more commonly seen in Parkinson's disease than you would expect, but also skin disorders that occur as a consequence of treatment of Parkinson's disease. And then lastly, I'll spend just a minute or two talking about recent research in a high-level nature into how skin can be useful in the diagnosis of Parkinson's disease. These are the main conditions we'll be talking about: melanoma, seborrheic dermatitis, and disorders of sweating. When it comes to cancer overall, the good news is that if you have Parkinson's disease, your overall risk of cancer is actually reduced. It's not reduced by a great amount, but by a slight amount, and that's been found in multiple studies all over the world. It's not true that all cancers are reduced in Parkinson's. Some are increased, and the main ones that are increased is actually skin cancers, in particular melanoma. The risk of melanoma is about 2 to 3-fold increased in Parkinson's disease after Parkinson's disease has started to manifest and has been diagnosed, but there's not an increased risk before the diagnosis of Parkinson's disease. We don't necessarily know a lot about why someone has with Parkinson's has a greater risk of melanoma, but there are lots of shared risk factors. So being older, being male, being Caucasian, having fair skin, red hair, certain toxin exposures can increase your risk both of Parkinson's, but also of melanoma. When we dig into pathology, pathophysiology, genetics of both conditions, we see a lot of similarities. As an example, there's a protein that builds up in the brain in Parkinson's called alpha-synuclein. If you biopsy melanoma and look at it, you will find that protein there as well. Certain genes that control, let's say, skin pigmentation also can modulate the risk of both Parkinson's disease and melanoma. And certain genes that cause genetic Parkinson's can also be found to be mutated if you analyze tumor cells from a melanoma. So there's a lot of intersecting and shared factors that connect these two disorders. It's important for me to point out, though, that there has been fear in the past that levodopa might increase the risk of melanoma or might fuel melanoma once someone has melanoma. But big studies have shown that that fear is not founded, and that taking levodopa does not increase the risk of getting melanoma or having worsening of melanoma over time. So what can you do to reduce your risk of melanoma? Well, the main thing is just common sense. Reduce sun exposure, use sunblock. Especially if you live in the sunny area, like where I am in Phoenix, Arizona, getting an annual dermatology visit will really be critical. You can also do your own surveillance by checking your own skin or having your partner check your own skin. You should know your A, B, C, D, E's of melanoma. Melanoma can be seen in this picture here. So the A is for asymmetry. The B is for an irregular border. The C is for color variability. So here we see purple, we see some reddish, pinkish color, black, brown, and light brown. The diameter greater than 1/4 inch is abnormal for a mole. And evolution, meaning changes over time, would also be something that indicates possible melanoma. So if you see any of those problems or signs, then it's time to see the dermatologist. Perhaps the most common condition that I see is a condition called seborrheic dermatitis. And when I walk into the examination room, this is often one of the first things that I notice. And I wouldn't say this condition is diagnostic of Parkinson's disease to any extent, but it does help raise my suspicion that the person may have Parkinson's. So what is it characterized by? Well, it comes on a spectrum from very mild, perhaps not even noticeable to the person with the symptoms, to very severe, where it can be a real cause of loss of quality of life. It's characterized by intense itching, burning perhaps, oiliness of the skin, and scaling, typically along the scalp, the hairline, the brow, around the nose, the chest, and then also around the mouth as well. Some studies have suggested that up to 60% of people with Parkinson's disease may have this condition. I think that number is a little bit high, but I would say I see it every single day. I see people with Parkinson's, so it is quite common. There have been several theories put forth to explain the association. There may be changes in hygiene. There may be changes in facial expression that lead to buildup of oily tissue or of oily substances. There may be changes in the immune system, how it functions, and there may be changes in the types of yeast that are present on the skin in Parkinson's disease. Luckily, though, this is usually very easy to treat. And the usual treatment is a topical treatment. It comes as a shampoo most commonly, and that shampoo could contain a number of substances like zinc, selenium, tar, and I've underlined the most commonly used one, which is ketoconazole. I would say if you try 1 or 2 of these treatments that are over the counter, that are topical, and is not working out, then I think it would be a good idea to see a dermatologist for a more specialized assessment. Another very common condition that actually is often seen prior to the diagnosis and prior to the manifestation of Parkinson's disease with perhaps shuffling and resting tremor and stiffness and slowness is increased sweating. Increased sweating is the most common change in sweat production, and in many cases it's related to Parkinson's disease. It may be related to disorders of what we call the autonomic nervous system. This refers to a part of the nervous system that controls the part of the body's function that we're not consciously aware of. So think about your blood pressure, your digestion, and also sweating. It could also be related to medications, in particularly antidepressant medication can cause sweat problems. But we have to consider also that Parkinson's disease is not the only thing that can cause different types of problems. And just because someone has a symptom and has Parkinson's disease, we shouldn't always automatically blame Parkinson's. So other medications might be causing problems with sweating. There might be other medical problems going on, like increased thyroid function with increased metabolic rate. There might be cancer, infection, or sleep disorders that could be contributing to this. So when you see the doctor, or the neurologist or the primary care doctor about this particular problem, it's really the doctor's job to figure out what might be the most likely cause. A lot of the time, increased sweating occurs and affects the head, neck, and the trunk, by the way. And typically it occurs in the medication off state. And the medication off state is the condition where there are more Parkinson's symptoms, more stiffness, slowness, and tremors. And then when you take medications, symptoms get better, and then you're in the so-called on state. So sweating can occur both when you're in the off state and also sometimes in the on state, in particular if the on state is with dyskinesia, which are these involuntary excess movements that are seen as a side effect of levodopa. In terms of treating this problem, if you identify off symptoms or the off session as the main cause of increased sweating, or if you identify dyskinesia as the main problem, then you try and adjust Parkinson's medications to account for that. You also want to review the medication list to see, was there a medication that can cause increased sweating that was started around the onset, the time of the onset of the problem? Then it might be a good idea to hold that medication for a few weeks to see if that helps. DBS is not an indication, or increased sweating is not an indication for DBS, but since DBS leads to a reduction of off time, leads to a reduction of dyskinesia, then DBS can improve increased sweating. Botox is sometimes used for very localized sweating. So if someone has a lot of sweating of the face or of the armpits, then Botox injections could be helpful. Certainly common sense interventions like wearing light clothes, drinking cold liquids, and so on can also be effective. We don't often prescribe medications. When we do, propranolol is sometimes used. Typically, if increased sweating occurs as related to anxiety, perhaps associated with social anxiety. We may also use topical treatment like glycopyrrolate, aluminum chloride, and then the dermatologist will have certain specialized treatments available, like this treatment called iontophoresis, which is primarily effective for sweating of the armpits, the hands, and the feet. An entirely different problem altogether is reduced sweating. This is 9 out of 10 cases is going to be medication related, so a side effect of treatment. Typical medications that can cause this problem will be your anticholinergics. So examples of anticholinergics would be trihexyphenidyl, amantadine, and glycopyrrolate. And it makes sense that glycopyrrolate can cause this problem since glycopyrrolate is also a treatment for increased sweating. These conditions are relatively less common in Parkinson's. Rosacea is seen in this picture, characterized by redness of the central face, so nose and cheeks, and often accompanied by a very characteristic nodularity of the skin, which I'm sure you can appreciate in this picture. If this person were to drink alcohol, there would likely be a flushing response. And very interestingly, it's been shown in a large database study of more than 5 million people that if someone has been diagnosed with rosacea, their risk of Parkinson's disease seems to be increased by twofold. Perhaps the most dangerous condition is what we see in this picture. This is bullous pemphigoid. About 50% of people with this condition also have a neurological condition, sometimes Parkinson's disease, sometimes something else. And one of the main problems with this condition is that these large blisters can break, and they can increase the risk of skin infection, which can lead to a blood-borne infection, and that can be quite dangerous. The last picture here shows redness and skin breakdown around the mouth, and this is caused by uncontrolled drooling. Luckily, this is easily treatable with botulinum toxin injections into the salivary glands in front of the ear and under the jawline. Now, switching gears a little bit, I'll talk a little bit about the treatment-related disorders, first talking about medications taken by mouth, and then we're going to talk a little bit about DBS and infusion-related therapies. The picture up here shows a diffuse rash of the skin. This is a not very common, but though a reported side effect of Carbidopa Levodopa 25-100, specifically that formulation because it contains a yellow dye. And the good news here is that if you stop that medication, the rash will go away. And if you need to be on Carbidopa Levodopa, then any other formulation of the medication, 10-100, 25-50, or Parcopa or Stalevo will not have the yellow pigment in it, and so will not cause this problem. This picture shows leg edema, and I think this may be the most commonly overlooked problem. A lot of Parkinson's medications can cause leg edema, primarily amantadine, and then the medications we know of as dopamine agonists. So that would be listed here: ropinirole, pramipexole, rotigotine, napomorphine. If the story is that a person did not have leg swelling, started a medication for Parkinson's, and then a few months later developed leg swelling, then most likely the culprit is the Parkinson's medication. And you can avoid having to do extensive testing to look for heart or lung problems. Typically, if the offending medication is stopped, this will go away within a few weeks to a few months. You could treat it with water pills and diuretics, but it typically does not work all that well. This picture here shows Meadow Vegicularis. It's not a rash per se. You can notice that the skin has kind of a web-like appearance, and that's caused by amantadine. And the precise mechanism of this skin disorder is probably related to changes in the blood flow through the skin. It's not dangerous, but it's not cosmetically pleasing either. So for that reason, some people might want to stop taking amantadine if they develop this skin disorder. For the surgical treatments and infusion-based treatments, I haven't included pictures of the actual skin complications. I thought it would be more helpful just to show pictures of the devices themselves, since I imagine that not everyone is intimately familiar with each of these three treatment forms. DBS is by far the most established treatment. There's a wire going into the brain, connected through a wire to a battery in the chest. This person has two batteries, but most commonly, there would just be one battery on the left side of the chest to serve both sides of the brain. In big studies, we see that about 5% or so of people who have DBS get some form of device infection. I would say in larger centers, high volume centers, that number is going to be much, much less. When device infection occurs, treatment with antibiotics might be required, and surgical revision, and indeed sometimes removal of the entire system may be necessary. And another rare skin condition with DBS is erosion of the hardware, like up at the leads or at the battery in the chest through the skin. And so that means that you can actually see the device through the skin as the skin thins and thins over time. If you have DBS, I would not worry. This is an extremely rare condition. I see a lot of DBS in my practice, and the last time I saw this particular complication was probably 4 years ago. This treatment here is Duopa. There is a feeding tube that's going into the stomach wall, and you can see the tube here. It will be connected to a pump, and this allows the person to get Carbidopa levodopa infused into the small intestine, either 16 hours a day on label or 24 hours a day off label. And this can be a very helpful treatment for people who struggle with a lot of off time and people who struggle with a lot of dyskinesia. Since there is a foreign body there, it can cause some skin-related issues, pain, redness, and infection can also be a potential concern. This can be mitigated and treated by proper hygiene, proper care of the feeding tube, and in some cases, antibiotics as well. The treatment that I suspect most people may not be familiar with is subcutaneous infusion of carbidopa, levodopa, or a medication called apomorphine. Both treatments have been trialed in the US, but is not yet approved by the regulatory authorities. It is another type of treatment that can reduce off time. And to give you an idea of how it works, this is a small patch that has a small needle on it. The needle hooks into the skin, and then the pump can basically deliver medication into the patch, into the skin, 24 hours a day. Another good treatment for, or another potential good treatment for off time and dyskinesia. Since there is a foreign body sticking into the skin, though, we still have the issues of pain, skin irritation, infection, and perhaps most commonly, where the infusion takes place, there can be some hardening of the skin, and there might be formation of small skin nodules that are not dangerous, but can be uncomfortable, and can be treated with rotating the site by using massage and by using an ultrasound device. The last thing I have to cover is skin and diagnosis of Parkinson's disease. So big picture, most people will have heard of a protein called alpha-synuclein. We have it in all of our cells, and it's important for a lot of functions, especially in the brain. In Parkinson's disease, this protein alpha-synuclein gets phosphorylated, starts to clump together, and may be part of the problems that drive Parkinson's disease. But if we do an autopsy on someone after they have passed away, we can determine that that protein is there in the brain, but we obviously don't do brain biopsies in life. So we've discovered in the past few years that alpha-synuclein is present in many other tissues, skin, eye, gastrointestinal tract, and so on. So the relevance here is that, can we locate this protein somewhere outside the brain, and can that be helpful in the diagnosis of Parkinson's? Real quick, the way we do it is by using this small punch tool to carve out a cylindrical biopsy. We send it off to the lab, and we try and determine if the protein is present in the skin sample. When this test comes back positive, then usually it means that the diagnosis of Parkinson's disease is correct, since that would be the most common cause of this protein accumulating in the skin. But it can be seen in a few other conditions like multiple system atrophy and dementia with Lewy bodies. When it's negative, I think it should lower your suspicion that someone has Parkinson's, but it is possible to have Parkinson's disease and have a negative skin biopsy, so it may be less helpful in that scenario. In the future, I think skin biopsy may be helpful in terms of establishing and confirming the diagnosis of Parkinson's disease, but there's more research to be done. And another way this could be helpful in the future might be to enrich research trials. So we know that some people who enroll in trials for Parkinson's disease don't in fact have Parkinson's disease. And so if this test can help us diagnose Parkinson's with more certainty, then that would help to eliminate that problem in clinical trials. I have a few take-home points, but they'll be in your slides online. So I'll just, again, like to thank everyone for tuning in, and thank you to the Parkinson Foundation, and I'll give it over to Dr. Lyles.
Thanks so much, Dr. Nieman and Dr. Beck. Thanks for the introduction. I need to thank another group of people, and that's everyone who's in the audience today. We very much appreciate your joining us today, and I need to thank you. I prefer when I speak to groups of people to ask them to hold up their hands if they pay taxes. Most people do in this country. And I need to thank you because if you've paid taxes, you supported my research over the last 35 to 40 years, and that's very important to me. I'm very interested in older people with skeletal diseases, and the other thing that's important is that in the last 6 years, I've been fascinated by the problems that are caused by Parkinson's disease when they have fractures. Duke University does not allow me to talk without my revealing my conflicts of interest. You've already heard that I'm president of the Bone Health and Osteoporosis Foundation. The National Institute of Aging supports me. I own a company that gives its profits to research at Duke University, and I am the inventor or co-inventor of 4 patents or patent applications dealing with zoledronic acid that you're going to hear more about. I have a great deal to cover. I'm going to have to go rapidly. The wonderful thing is that the Parkinson Foundation will make all these slides available for you to review at your leisure. I want you to understand why patients with Parkinson's disease are at higher risk for skeletal fractures. I want you to appreciate the fact that if you have PD and have a fracture, you'll have a lot more disability and longer recovery. And then I want you to recognize there are treatments to reduce fracture rates in patients such as yourself, and there are research opportunities to help better understand ways to prevent these devastating consequences. My passion is fractures. This is a hip fracture in a 72-year-old man. He got out of bed, slipped, and fractured what we call the femoral neck of his left hip. You see the yellow arrow pointing to it. Hip fractures are devastating. There are 280,000 a year in the United States. 12.3 million people in the US are expected to have osteoporosis by 2020. If you have a hip fracture, 25 to 30% of people die in a year. The cost is massive. There are more fractures than heart attacks, strokes, and breast cancer combined, and the cost of treating this is more than the care for these problems. The big problem is if you have Parkinson's disease and have fractures, you have a great deal more disability, and you have a greater risk of having a fracture. This is work that was led by my colleague, Dr. Steve Cummings, who you'll hear more about. But the point is that when you look at the published literature, you'll see there's an increased risk of fracture, okay? And patients who have PD have more disability after. To summarize the impact, they occur 2 to 3 times more frequently in people with PD than those who don't have it. But remember, if you're a woman in the United States, half of you will have a fracture before you go to glory, a quarter of the men. And if you're blessed to make it to age 90 as a woman, you have a 1 in 3 chance of a hip fracture. If you're a man, a 1 in 6 chance. The bad news is at best, only 5% of people with PD have fractures that are treated medically to try to reduce the further fracture rate. And then it's very clear that after a person with PD has a fracture, they have more disability, it takes longer to recover, they lose more independence, and there's more cognitive decline. Now, I'm not going to go through every single line of these next few slides. However, if you have a fracture or you consider you're at risk, you need to discuss this with your health provider. There are ways to assess your bone strength. Doing DEXA testing. Men over 70 ought to consider it. Women 59 to 69 ought to consider if they have risk factors. Remember that 2/3 of fractures in the spine, they're called vertebral fractures, never come to medical attention. What are some of the risk factors for osteoporosis? unfortunately increasing age, being a female, if you have a family history of someone who's had a hip fracture in an immediate relative, that is a reason to be concerned and you're more at risk. Smoking increases the risk of bone loss as well as fractures. Too much alcohol, what does that mean? More than 2 drinks a night in a woman, more than 3 for a man. Low body weight, under 120 pounds when you were age 18 or when you were 25. If you've had a fracture, the best predictor of having a fracture from osteoporosis is a prior fracture. We think about it really in terms of after the age of 40 or 50. If you are someone who is bent over, whether you have what we call a kyphosis, because you're bent over because of fractures in the spine, that's an increased risk. And then the drugs, glucocorticoids, the other term for that is prednisone, dexamethasone, budesonide. Those drugs, although they're very effective at treating a number of diseases, you have to pay the piper. 2/3 of the people who get those drugs have bone loss and are at risk for fractures. This is a very busy slide. Many medications can put you at risk for bone loss. You need the medications for very good reasons. Aromatase inhibitors save people's lives that have estrogen receptor positive breast cancer, but they take a toll on the skeleton, causing bone loss and fractures. I've already alluded to the fact a number of neurologic diseases, epilepsy, stroke, multiple sclerosis, and Parkinson's disease, real increased risk for fractures. And a lot of this is because people fall. There are GI diseases, rheumatoid arthritis, cystic fibrosis, diabetes, low testosterone, or people that have a premature menopause, and then a number of chronic diseases, kidney failure, lung disease, HIV. All of these are diseases that put you more at risk for having osteoporosis and fractures that go along with it. You make the diagnosis with bone density. We don't need to go through this because you can review this on your own. Remember, if you've had a fracture, you need to make your healthcare provider aware of it because you're at increased risk. And if you don't know, someone ought to consider a bone density, okay? There are therapies. That's what's really important. There are both non-prescription therapies as well as prescription therapies. You need to stop smoking, limit alcohol, and be careful when you use sedating medication. What is the huge bugaboo? Fall prevention. I need to say that again. Fall prevention, physical therapy, regular exercise. And one of the other people critically important to our work in the Topaz trial, which Dr. Beck alluded to, is the fact that exercise may be one of the ways, or in fact, the only way to reduce the progression of the Parkinson's disease. You need adequate intake of vitamin D. We now recommend that you want 1,000 IUs a day of vitamin D3, no more, because more than 1,000 increases your risk unless you have some problem and you don't absorb the vitamin D normally, and you need some calcium. It can occur with supplements if you're not someone who is able to use dairy products, either because of lactose difficulties or because you don't want to gain weight. There are also medications now that over the last 35 years, we have learned prevent fractures. Estrogens can be used. A special type of estrogen estrogen, known as raloxifene or a selective estrogen receptor modulator. And then the big medications we use are medicines that stop bone breakdown, anti-resorptive medications such as bisphosphonates, and those would be Fosamax, Actonel, Boniva, and Reclast. I'm going to talk a little bit more about Reclast to you in a minute. Denosumab is Prolia. This also reduces fractures. And for the more severe types of osteoporosis, what we call anabolic medications have to be given by injections. The first two, teriparatide or Forteo or abaloparatide, you give yourself an injection just as you do insulin every day for 2 years. The most recent one we've had it added to is romosozumab. That has an ability both to stop bone breakdown and make you make new bone. That's given by a subcutaneous injection, usually in an infusion clinic every month for 12 months. But let me go back to something. I cannot remind you enough. If you've got Parkinson's disease, you have 2 to 3 times more risk of having a fracture, and hip fractures occur 4 times. Remember, less than 5% of those people who have PD are treated, and there's much more functional disability when you've had a fracture. You know the real sad story of Michael J. Fox breaking his humerus. That's the upper bone in the arm. He writes very passionately about his difficulty because he had long convalescence and it occurred from a fall. It can happen to anyone. For the last 6 years, I've been working with these 2 people, very good friends of mine, Dr. Steve Cummings, world-renowned investigator in the bone field. Stephen called me in August 2016. My phone rang. I was at our daughter's home in Washington, D.C. He said, Ken, Carly Tanner and I think we can do things to reduce fracture rates in Parkinson's. You know a little bit about zoledronic acid. Would you help us write a grant? I said, we've been talking about it at Duke University. I'd love to go along with you. Let's do it. Carly Tanner, world-renowned Parkinson investigator. She leads the group at UCSF. One of her major interests is how do you simplify and develop systems so that you can have patients get the advantage of care in their home without coming to a clinic. Those 2 people are the lead investigators on a trial we won after 25 months of planning a trial we named the Topaz trial. What we're going to do in this trial is use a drug called zoledronic acid or Reclast. This is a very potent bisphosphonate that stops bone turnover and bone loss. This happens to be from a paper that I led the group to do the research, published in 2007. If you've had a hip fracture and you're over the age of 50, you have a 20% chance of another fracture in the next 24 months. We realized that, convinced the company that it was a trial worth doing. It was difficult to do, but we showed that if you give someone 1 shot of zoledronic acid every year, you reduce the subsequent fracture rate, by 30 to 35%. The effect lasts for 2 years. You don't have to take it every week or every month. But what really surprised people and made people look is not only did we reduce fractures, but we had a 28% decrease in mortality that has subsequently been shown not to be just a fluke of the study. It's very real that this class of drugs does this. So what did we do? Again, a large number of us worked very closely with the people at the Parkinson Foundation. They're part of this trial called the TOPAZ trial, treatment of Parkinson's and zoledronic acid. We received funding for this trial, and what Dr. Tanner was so good at is how do we make it possible for you to do this trial and never leave the privacy of your home? If you have a neurologist who's a member of certain groups, either the Centers of Excellence or the PSG, Parkinson Study Group, they can just refer you to a website or send information to Dr. Tanner if you're willing to do it. You can call the Parkinson Foundation for help and they'll let you do an e-consent. That means do it online. And friends, I'm a klutz with computers. Steve Cummings is not, but both of us easily could do the informed consent online. So it's easy to do. Once you've signed that consent, that gives Dr. Tanner the ability with her colleagues to get your medical information to make sure that you would qualify for the trial, okay? If you have had certain neurologists, such as our PSG neurologist, examine you, you don't need to have an evaluation done again by computer in the privacy of your home. But if necessary, they'll come to you, they'll make an appointment, and they will do an evaluation of you in your home using this computer. Again, both Cummings and I have had it. It was easy to do. We don't have Parkinson's, but we know this works. Then what will happen is once the diagnosis has been confirmed, your name will be given to a group of clinical trial nurses that are part of something called PCM trial nurses. They're housed in Denver, but they cover 95% of the zip codes in the United States. They'll make a phone call to you. They'll ask you some questions. They'll check about your oral health to make sure you don't have any trouble with your bones. They will then set up an appointment and come to your house to check kidney function, to examine you, to look in your mouth, and then give you this infusion of zoledronic acid or placebo. Remember, when you enter this trial, you have a 50-50 chance of receiving zoledronic acid or placebo. And that's the only way, because none of us know what you will be receiving. There are people that know if we ever have to ask a question and find out if you received it. But this is what is known as a double-blind placebo-controlled trial. This is very easy to become involved with. We want to prevent your fractures. We do it based at home to reduce the caregiver burden and your burden on people who participate. There's no clinic visit. We have a study site, and this is the number where you can call and talk to people at the Parkinson Foundation. They can help you. And oh, by the way, when there are really questions they can't answer, Dr. Beck, Sharon Metz, many other people at the foundation have my cell phone number, and I'm available, honestly, 24/7. These nurses for PCM trials are fabulous people. They're all research nurses, extensive experience. They're trained. They know how to do this. If you're in our business of doing clinical trials, you have to be certified for clinical practice. It's called GCP, or Good Clinical Practice Certified. Also, these people have received training on things about Parkinson's disease. They understand about the drugs. They know how to do the oral exam, because we want to make sure you don't have any trouble with teeth. If they find a problem, they take a picture. They then call me, and your picture of your mouth is sent to a private box that I access through my cell phone. I hear from these people 7 days a week. My last picture came in Tuesday afternoon. The question about the mouth was easily resolved. The person received their study drug in their home. So the point is, we have partnered with an exceptional group of people, and our patients that participate in the trial thoroughly enjoy their presence in their home. Now, let me go back to what I wanted to do. I hope that I've at least made you aware of the fact that people with Parkinson's disease are at higher risk for skeletal fracture. When we did the work to tell the National Institute of Aging that they ought to fund us, we realized that someone over the age of 60 with Parkinson's has a 10 to 16% rate of fracture every year. That's unacceptable. You have more disability afterwards, and I hope I've convinced you there are treatments that can reduce fracture rates, and we would very much appreciate if you would consider, if you meet the qualifications, being part of our trial, because our goal is to try to help show there are ways to reduce this horrible fracture burden with a fairly easy medication to administer. I want to thank you for listening. I want to thank Dr. Beck and the Parkinson Foundation, and I hope you're aware of the fact that I want to thank my collaborators at UCSF, Dr. Cummings, Dr. Tanner, and other members of the Topaz staff. I'm going to stop, and I hope I haven't gone too long, Dr. Beck.
Not at all. Thanks very much, Dr. Lyles. And if Dr. Nieman can come back on, we can start a Q&A time. That were really two excellent talks covering a great range of topics. And Dr. Nieman, I just for our audience, do you want to let folks know what the wall art is behind you?
Oh, yes, this was actually left over to me from my predecessor. This is the molecular composition of dopamine.
Fantastic. I think just showing a real diehard focus on Parkinson's disease. And so let me have the first question go to you, Dr. Nieman. You covered a lot of issues, and I thought it was really interesting, talking about some of the problems with the autonomic nervous system. And there were some interesting ways to deal with it, primarily trying to control being off. However, what about at night? So one of the questions comes in asking if there's a PD safe treatment for night sweats, when people generally are not awake to take their medication, and how would you recommend people deal with that?
Again, I think it comes down to pinpointing why is it happening at night. I think the most likely reason why it's happening at night for most people with Parkinson's is because at night, as you said, they're not taking medications. So they may take their last dose of Carbidopa, Levodopa at 6 p.m. and then they don't take anything until 7 or 8 a.m. the next morning. So they're effectively off all night long. If that is the case, then I would add on a low dose of an extended release Carbidopa, Levodopa at bedtime, either the Cinemet controlled release, or in some cases, Rytary, which is another long-acting Carbidopa, Levodopa.
Yeah, interesting. And I know that we have some fact sheets around sleeping with Parkinson's, and I know that perhaps some things to keep in mind if you can't control night sweats. Different types of material for sheets can help, just so that you don't feel as drenched. I believe satin sheets are recommended for people with Parkinson's, primarily just to help people turn over at night. Can be very difficult, as we've just talked about. Some people can be off as part of that issue. Dr. Lyles, next question for you. We talked a lot about different supplements, not necessarily, but other things that can be taken about diets and foods and how that can affect bone and joint health. So first one you mentioned, vitamin D. How can that impact bone health? And then you mentioned vitamin D3, vitamin D2. What is someone going to find as a potential supplement if it's recommended at CVS or Walgreens?
Sure. I think the simple answer to that is You want to look at what you're receiving, and for almost everyone, 800 IUs to 1,000 IUs of vitamin D3. That's what your body makes, cholecalciferol. That's what should be taken. The important thing is it was only last December that we learned from colleagues at Johns Hopkins that more than 1,000 IUs of vitamin D3 puts people over the age of 70 at risk for falls, and we have got to do everything within our power to reduce the fall risk. Now, the caveat is, if you have any kind of problem like celiac disease or you've had a gastric bypass, you may need to work with your provider to make sure blood levels are done, that 1,000 IUs gets you up to that 30 to 40 nanogram per ml range, okay? But D3 is the one you prefer. D2 is a plant thing. It may be a little less effective, but most people have no trouble getting vitamin D3.
Fantastic. And so just staying on the vein of potential supplements, you hear about collagen. Is that recommended? What about calcium? Beyond vitamin D3, are there other things you advise your patients on?
Well, if you're talking about nutritional elements, if you have osteoporosis, you're at risk, you've had a fracture, we think you need some extra calcium. But one of the things we're sensitive to is that the pills are large, and Parkinson's can give you swallowing trouble. So you may need either to break the pill or get a chewable form, okay? Remember also, you can use dairy products. A glass of milk or a glass of some of the soy-based have about 250 milligrams. And people are gonna need a total intake of 1,200 milligrams to 1,500 milligrams a day. Your diet has 500, so it then gets pretty easy to do the math. You may take 2 things of calcium citrate, 2 of calcium carbonate, and you may need, though, to break them up. Remember also that calcium supplements cause constipation, so you may need either to increase your fiber content in your diet, or you may increase the amount of fluids you take in. But the foundation has that ability to pass that information on to people who will call your helpline.
Okay, fantastic. Dr. Nieman, we talked a little bit about skin cancer, and it's curious about why skin cancer is, question came in more at risk than regular cancers. But if someone does have skin cancer now and they have Parkinson's disease, is there anything they should let their treating physician know about PD that may impact their care, or is it something that can be treated independently of their Parkinson's?
Yeah, I would say something that can be treated independently of their Parkinson's. I do sometimes have people come from the skin doctor. They have a diagnosis of melanoma or another type of skin cancer, and they tell me that their dermatologist told them to talk to me about use of Levodopa. And this just goes back to what I said during my part of the session, that Levodopa really does not increase the risk of cancer and does not increase the risk of a worse outcome with something like melanoma. So yes, the skin condition can be treated separately from Parkinson's.
Fantastic. And I know that we only have you for a little while longer, so let me just ask a couple more questions of you, if I may. And I know Dr. Lyles has graciously been willing to stay a little longer, so we've got lots of questions. So thank you. Again, about the skin, some people as they age, their skin becomes a little more fragile, yet more prone to abrasions. Lotions don't seem to help for some people, and like real thick stuff like Vaselines or greasy things don't help. What do you recommend for your patients to help maintain good skin health? That may be a topical approach for them if they're complaining about some of these issues, scaling, and as we've talked about, some of these dermatitis that you've described.
Yeah, I think it's important to make sure that you're not putting yourself at risk of your skin drying out, like using a lot of alcohol-based products like colognes and deodorants and perhaps hand sanitizers as well. But other than that, I mainly recommend fatty emollients, so fatty lotions that can be applied to pretty much any part of the body. It's very rare that I see someone where those simple interventions don't work. But in those situations, I do refer the patient over to the dermatologist for more specialized care.
Yeah, I know that my son has some troubles with eczema-like issues, and we use Sarna, which is seems like a very lightweight anti-itch, kind of non-medicated lotion, which is helpful. Yes. Again, thinking about, and this may be an area, especially in Phoenix, where people have dry skin. It's like it's hot. It's like an oven. Because it's hot and dry. But battling dry skin can affect the nails too. So is that these issues that people experience with the skin, impact hair, nails, and what do you recommend, if anything, to do about that? I mean, where people may have like splitting nails because it's so dry outside.
Yeah, I would count myself as one of those people. Since I moved here from Texas, which is very humid, my skin is dried up, my nails are splitting, my hair is dry. I've found that a fatty lotion really works wonders, and a gentle shampoo helps to avoid drying out of the scalp and the hair.
I should have recognized that Texas accent of yours. I apologize.
Well, Texas must have a Danish accent, I'm sure.
Yeah. I'm just teasing. Thank you very much. And I know you may have to go, so I'll let you go and continue on some questions with Dr. Lyles, if I may. So, Dr. Niemann, thank you for your time today, your presentation. So, Dr. Lyles, we talked about things that can help bone health. Are there things that can negatively affect bone health, like foods or drinks, or maybe even PD medications that can negatively affect bone health? Are there things to watch out for?
I cannot stress enough. Remember, you may or may not enjoy alcohol, but that can be a huge thing that impairs you. So you want to be careful again. Most of us say 2 drinks for women, 3 for men. Some of the medications we use to help you sleep can increase the risk of falls. Some of the medicines you may take for depression can cause the fall. But part of this is that you have to, there have to be benefits that if you have real trouble with depression, you just may need to be aware of this. And if you take a medicine that you're treating your blood pressure, you may have to learn if you're going to get up at night, maybe to use the bathroom, you may need to dangle your feet and not charge into the bathroom. So I think those are important things. Please, 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 just remember you don't want rugs that slip in your home. As far as drugs or foods that you shouldn't eat, I don't think there are any that should concern you. Years ago, people worried about caffeine. That causes a small amount of calcium loss in the urine. However, if you put a little milk in your coffee, then you're not going to have that kind of problem. But other medications you just have to accept, such as prednisone, dexamethasone, that class of drugs are the drugs that you use to treat people who get transplants. If you don't have those drugs to suppress the immune response, you're not able to keep the lung, the liver, the heart. So I think most of the medications, we can overcome the effect, or we can watch the density and decide when we need to step in. I can't get away from the horrible fact, though, that if you have Parkinson's disease and you're over 60, this 10% rate of fracture, and we got that data, is Dr. Cummings, Dr. Tanner, and I prepared to get the grant. 10% a year is just unacceptable. We have to see what we can do to reduce this fracture rate. And that's again the goal of copay. No one's ever focused on it. I love neurologists, but that's not what neurologists think about when you go in to see them. And we want to change the dialogue.
Yeah, absolutely. I mean, I think we agree, an urgency in identifying ways to help people with Parkinson's disease. And unfortunately, leading causes of mortality are falls, either direct
You're
from
so
falls
right.
or as
You're
we
so
talked about,
right.
the sequelae, the trying to recover from hip fracture, which can be really terrible. Before, got lots of questions about Topaz. Very convincing, I think, the importance and need of it as a research tool. But for those people who, we talked about recovery from a hip fracture can be very difficult for someone with Parkinson's disease. What about those who maybe have bad hips already and looking to get a hip replacement? Do you anticipate any particular difficulties for a person with Parkinson's, for who may be ahead of the curve, avoiding issues, either because they've got arthritic hip or recognizing that maybe they have problems that need
Okay.
preventative care?
I think it's important if we're thinking about a hip replacement because you have arthritis and need a hip, and you and your orthopedic surgeon decide you need it, they ought to go ahead and get that. Okay. Now, just remember, it may take longer for you to do the rehab because you may have difficulty with movement and getting about. To be careful. That would not, as long as you've not had a hip fracture, that's not going to preclude if you want to do the Topaz trial. If you want to do the Topaz trial and have had a hip fracture, you need to take yourself to your doctor and say, I know there are medicines that will reduce my risk of another fracture that I have. Oh, by the way, could you consider getting me treatment for my osteoporosis? And oh, by the way, take this slide deck from today's talk and show it to them. So that's hopefully a gift to patients. Hopefully no one on this call has had a hip fracture, but I suspect there are people, and that needs to be taken on. The bad news is we know it's a huge problem in the osteoporosis world. Of the people in America that have a hip fracture with good therapies to reduce the risk, only 3% get treated. Okay, so I'm kind of passionate about this. But your Parkinson patient who's already had one, they need to talk, the neurologist say that ain't me, and send them either to an endocrinologist or rheumatologist or their primary care provider. This should not go untreated. They have osteoporosis.
That's a really good point. And so when we talk about osteoporosis, would you say it's not Parkinson's that's causing it, it's aging, and it's Parkinson's that's putting them at risk for falling, which is then where the fracture is coming in. So, I mean, is that, and I think you mentioned that briefly when you talked about secondary risk factors for osteoporosis and fractures. There's a string of neurologic diseases you mentioned where falling seems to be the key component. And as we know from our Parkinson's community, people with PD fall a lot.
Well, there are a couple of responses, and my vast knowledge on this comes from my colleague, Dr. Tanner. One of the points she makes is we know that when you take populations of patients with Parkinson's disease, they have lower bone densities, and they also get that stooped posture. Okay, that may not cause the fractures per se, but if you have a lower density and you fall, you're going to have the fractures. Now, can I give you a mechanism, the beautiful way that Dr. Niemann showed me some of the work on the new protein they're studying? I don't think we can say there's something that happens in Parkinson's that alters bone metabolism, because remember, exercise is loading your skeleton every day helps keep the bone strong. People with Parkinson's don't move as much, more inactive. The other big example of that is when we send astronauts into space. They lose, okay? They lose bone. People that have strokes and don't move an arm lose on the side that's paralyzed. You see? So it's the lack of activity that can increase the amount of bone loss that occurs.
Yeah, I think that's a really important thing to highlight, is that people with Parkinson's, as we advocate and as clinicians like yourself do, getting up and exercising is so important
Oh,
as
yeah.
part of that. Not
You're
only does
so
it
right.
you make bones strong, but I think it also plays a role in strengthening muscles so that
Oh,
people, if they do fall, they have the strength to catch themselves, perhaps to minimize what could be a catastrophic
you see,
incident.
it was in 1989. I've got a reasonable memory that the first person really to point out, and I happened to be the person who reviewed, one of the reviewers on this article. But Steve Cummings wrote an article that said hip fractures are caused by falls. And when you're older, you don't put your hands out. So you end up falling on the hip as opposed to falling on your hands when you break your wrist. So that was an article, it's either 87, 88, or 89. And that just pointed out that as you age, you fall differently. You see your gait speed slowed down, and it helps us just think about the mechanism of the particular bone that fails or fractures. Okay.
Yep, absolutely. So I know we only have you for a little bit longer. So a couple questions about topaz.
Sure.
We have a lot of people calling in from throughout the world. Is this for U.S. residents only, or can people in Canada and Europe participate?
We'd love to have them, but they're going to have to come to America. I'm sorry. But we have gone after people or recruited people from Alaska. I'm not sure right now about Hawaii, but you need to be in the United States.
Yeah,
Sorry.
we need to be able to get the transfusion to them through the nurses. Now, if someone's already participating in a clinical trial, maybe it's observational or they're doing stuff online, can they still participate in Topaz?
You know how I'm going to answer that question? We're going to let Dr. Tanner and all her colleagues decide. Probably if they're receiving a medication may not be possible. Observational, we would think so, but we need to respect other colleagues who are doing trials. And if someone's, I think we can handle that. That is not a problem because we have people 24/7 who are willing to try to answer the questions and see what it will take. But we can get to you if you live in the United States. These PCM trial nurses go anywhere and are happy to see the patients, and then they provide the medicine in the home.
Yeah, I think that's one of the great innovations in this trial is that people don't have to leave their home in order to participate.
You don't have to leave home to get it.
And people, especially in time of COVID, everyone is very aware, especially these are nurses, health professionals who are very cautious about safety in general, and especially some of these times.
The PCM trial nurses bring masks for themselves and for the patient.
That's fantastic. So everyone's staying safe.
Okay. That's
a great thing. And so we have lots of information on our website about Topaz. There's topazstudy.org. For those who are interested, and as Dr. Lyles said, there's opportunity to sign up online. And if you happen to be at one of our centers of excellence or have a clinician who's part of what's called the Parkinson Study Group, they're movement disorder specialists who's really active in that area of academic Parkinson's research, they can also help facilitate the process for enrollment in the trial and help skip a step, just confirming whether someone has Parkinson's disease or not. If you have any questions, of course, we have our 800 number, 1-800-4PD-INFO, as well as you can email our helpline at parkinson.org, helpline@parkinson.org. With that, Dr. Lyles, I want to thank you for your time today. And I think what a wonderful presentation about bone health, how people can actively, take steps in their own hand to improve it. And that research study for Topaz, which, the Parkinson's Foundation is involved in, because we really believe, as you do, that it really offers an opportunity to understand whether something like zoledronic acid could be a preventative to help minimize fractures, which is such an important thing in our community. Yes, absolutely.
Zoledronic acid was approved as a treatment for osteoporosis, honestly, as a result of two trials, one done at UCSF, the other let it do, in August of 2007. This is an FDA-approved medication that is used worldwide. We're just trying to look for another time and place and way to help people with a huge need. Thank you.
Yeah, that's absolutely right. This has been around it's not an experimental medication. It's just trying to find out if we can do this prophylactically ahead of time to minimize fractures in a population we hadn't recognized that could benefit from this. And so I think that's really the novelty here is repurposing an existing drug to provide its help for people with Parkinson's. And it's something that, because it's an infusion, it's not inexpensive, and we need to have the evidence to demonstrate its success and efficacy to convince insurers that and clinicians, this is the right way to treat people with Parkinson's disease. So I think it's an opportunity to improve care for everyone. So with that, Dr. Lyles, I'll let you go. And I just want to thank our community again. If we can just show the slides, we've completed 3 expert briefings in our series. We've got 3 more to go. And I think as I mentioned, we've completed the one for this year, our 3rd one for this year. We've got the next one begins Wednesday, February 2nd. So we'll look forward to speaking with you then about the sights and sounds of Parkinson's. If you have any questions, in addition beyond what were covered here in our expert briefings today, the Foundation has a tremendous number of resources and support for you. And if we can have the next slide, then we can, we have our Aware and Care Kit for those individuals who are concerned about hospitalization. It's a handy kit to have to help facilitate conversations within the hospital, advocating for your loved one about getting their medications on time. We have our podcasts, of course, extensive library of materials, archived, not including fact sheets, but also expert briefings like this one and other ones we've had over the years. And again, also recommend when we talk about clinical trials, PD generation, an opportunity for people with Parkinson's to get no-cost genetic testing to understand whether they have one of the rare genes that may be affecting Parkinson's disease. And hopefully an opportunity to take advantage of it with next generation clinical trials. So if I can have the next slides. As we've said, please check out our website, parkinsons.org, our helpline, 1-800-4PD-INFO, and you can always email if that's easier for a longer question. Our helpline is staffed and very busy. Sometimes you may have to leave a message. They will call you back, so feel free to do that. We have talked to over 20,000 people a year, and we're here to help you, those with Parkinson's. And last, before you go, when this Zoom webinar closes, the screen is just going to kind of go blank. It's kind of the way things go today. There's no real slow denouement, but a survey will pop up in your browser. Please complete that survey. We really value that information. We share it with our presenters, and we use that information always to constantly improve our own expert briefing so that what we're doing matters to you the most. So with that, I wish everyone a happy holiday season, and thank you very much for your time today, and we'll see you again in 2022. Thanks again to our speakers. Bye-bye.